pseudoephedrine or ephedrine. So I know what I want you to go. Now you have agonist, antagonist. This is the second time I'm repeating. Please go do a table. What are the adrenergic agonists? What are the adrenergic antagonists? Make sure what are their major use. While I was leaving مين اللي سألني وأنت كنت موجود وطبعا وطنشتوني you did not send me an email. بس أنا كتبت الإيميل. Who asked me the question about alpha activation? فين I cannot remember him. Who asked me these questions? Is not here. So, one of the students, they asked me, I remember, and I prepared the answer. I was going to send it, but I don't have it. Then I asked someone to give me the batch leader. Be 22, slide 22, agonist. I was talking about alpha 1 activation. At the bottom, which is not related to the, I talk about inotropic, chronotropic, has nothing to do with alpha. I want to remind you of, when I left, he asked me, is it related to alpha? I said, no, this is heart rate to cardiac output. Is related to what? To which receptor? I just put it, I don't know why I put it in this slide, just to remind you what does it mean inotropic and chronotropic. No, I'm sure some of, from the blog, they ask me this question, or they forget it. So that's why I added. Now, we finish adrenergic agonists. I hope you've done your table. Trust me, don't leave it till the end. The best thing, if now, when you finish tonight, go adrenergic agonist, antagonist, and have them a table, and then make another table, cholinergic agonist and antagonist, okay? Remember, I told you parasympathetic is the dominant, right? Remember, always, if the sympathetic activation, increasing heart rate in the sympathetic, will be in parasympathetic? Decreasing heart rate. So if we give a blocker in case of sympathetic, what will be the same effect of having the parasympathetic, right? Now, sometimes when and how we will choose to give beta blockers or we give cholinergic agonists to decrease heart rate. This you have to relate these things. You will find later on medication, which is, they give the same effect, but why we prefer this over this one? Why should we prefer? Why should we prefer? Do we give cholinergic agonist or adrenergic agonist, adrenergic antagonist to block the heart rate or to decrease the heart rate? Why? Why we don't give cholinergic agonist?
Because ACH or the P can be. I think it would have a big range of effects if we give the cholinergic rather than giving the.
So you have to understand really the neurotransmission. Remember, you have now today I have one question. I think you've taken. Did you take the pilocarpine with Dr. Manal? Yes. What does it do?
Pilocarpine is for the eye.
Yes, ophthalmologic drug. What does it do?
Basically, it helps in meiosis and helps in the humoral flow inside the eye.
Okay, so now we have one of the beta antagonists, the Timolol. Okay, also is given in the same case as pilocarpine. So which one they preferred? Pilocarpine. Although yesterday I was in the ophthalmology clinic, they used Timolol. Okay, so is it because of the ability of some medication on both ways? And if it's a cholinergic agonist or sympathetic cholinergic agonist or sympathetic antagonist, sometimes there is one is preferred over the other one totally, or sometimes you might find in both ways. So always remember, لأن الأgonist الopposing تبعها is what the antagonist of the other one. Is that clear? Today, the adrenergic antagonist, remember when we are talking beta 1, I'm going to send you the email and please circulate it about the alpha. Well, I received today a questions. I want you to answer it. And I will answer her, the one she sent it to me, or I'll see later on. Does alpha-1 activation causes vasoconstriction in skeletal muscle or smooth muscle? I'll not answer it, Lena. You should know this, memorize it by heart. When it's written in the book. Skeletal or smooth? Smooth. Did I mention skeletal? I said except skeletal, okay? What about how is alpha activation phenylephrine used as nasal conjunction? Also, it causes vasoconstriction. أصلاً she answered it because it was a vasoconstriction of these vessels, okay? I will answer her and I will forward for you so that if anyone. Now, today we will just go with alpha blocker or beta blockers. Do you have any questions? Please, when you leave, يعني, when is your, if you have midterm or final directly? Final? I know, but there's no another midterm. So يعني عندكم big chunk. Anytime you need any questions. وأنا أتمنى يعني really this is what I wish. If you have a table of adrenergic agonists, antagonists, cholinergic agonists, antagonists, and you want me to share it with me and we come discuss it, I have no problem. But it should be done by you. And really you understand all the concept and what are the receptors, what is the second messenger. This is where you will be asked. What are the main uses, main side effect, and if there is, we did not give you any interaction, okay, drug-drug interaction. Maybe today I'll give you. So we need to know the therapeutic uses, and please do not use, the adrenergic antagonist. Last year I gave it, and this year I have changed things because I realized there are some drugs are obsolete, but I cannot remove them because you have to know the basic. If I remove them, later on, if they will give you any medication that will act on the same pathways, you have to remember at least those medication. وبعدين في concept of certain medication. When we talk about blood pressure is affected by what? How many system will affect your blood pressure? What else? What else? The heart. So there is always an overall effect, okay? When it comes the drug today, and I just make it simpler and simpler. Lena, I remember before they asked me too many questions. I feel it's not the right time to give you all details, because when you will take the cardiovascular block, you will know more and more, and how many system is affecting your total blood pressure. And then you have the drug affecting sympathetic transmission. Now, in the affecting sympathetic transmission, the medication I put, they're obsolete, and except one. The other medication, which is, remember when we talk about cocaine with tyramine, there is again guanethidine, but later on there are many medications that are related to the same. So you remember always your medication is acting on receptors or anything at the time of transmission, from the synthesis till storing it till releasing it. Now, this is just a review. I wish you do table like what I'm doing for you. Alpha 1, what does it mean? Alpha 2, beta, GQ, GR, GS. This one, this is the way I could remember things, myself, not at, like this one, but this is the way I make it simple. So always you see Alpha 1, Alpha 2, beta, do your own, then make it on adrenergic, cholinergic, and make all the comparison among them. Remember when we say alpha 1, it has subtypes. The more we have tamsulosin. Now, if I tell you alpha 1 antagonist for benign prostate hyperplasia, where alpha 1B controls vascular tone. So would you give, start to think deeply with me, an alpha 1 antagonist to control bladder sphincter, alpha 1 antagonist, or it's better to give alpha 1A, and why? يا رب حدا والله بزعل لو ما سألت. You have to answer me this.
I didn't understand the question.
I'm telling you, if alpha 1 is an antagonist for the alpha 1 for benign prostate hyperplasia. So now I guess, if a benign prostate, it will put pressure more on what? The urinary bladder okay. So you need to what? Give it an alpha 1 antagonist to relax this, okay? Which is better for this patient, to give him alpha 1 antagonist or alpha 1 antagonist? It's written here in front of you. Alpha 1A. Why?
Because the alpha 1 agonist is
Antagonist. I'm talking, would you give him antagonist, which is alpha 1, or you give alpha 1A? Regardless if I put, but you have to tell me why alpha 1A.
Because the alpha 1A receptors are still in the system.
And because the most important alpha 1 is what? Affecting what? It causes vasoconstriction. So what do you want this patient to, yeah, it's controlling the vascular tone. So you want the patient to have what? An effect on the prostate or on the vascular tone? So before we give them alpha 1, until they find this tamsulosin, they give it to what? To act on the prostate. Is it clear? I will repeat it later, hyperplasia or hypertrophy. And then you have beta 1, beta 2. Beta 1 is what? For the heart, and beta 2 is what? Bronchodilation, okay? And also on what? On smooth muscles, okay? Sympathetic activity. Now, when you say excessive sympathetic characteristic of several pathological states, which is cardiac arrhythmia, angina, hypertension. So that's why I tell you when you will take the cardiopulmonary, you will hear a lot about this medication. As not only, you know, a cardiac patient, will he take one medication? A cardiac. It's so today, if I mention beta blockers, it doesn't mean he will take only the beta blockers. He will take other medication. You have in case of angina, or if you have blood pressure, so you have to add more and more medication. Now these are the adrenoceptor antagonists. You have what? Alpha and beta. We have, let's start with the alpha 1, which is the selective. So we have selective and non-selective, okay? The selective is you have prazosin, yohimbine, and non-selective phenoxybenzamine and phentolamine. You have reversible and irreversible. Which is reversible, usually we favor the reversible because the reversible is a longer duration and it might cause more side effects. Beta blockers, you have beta 1, selective, which is atenolol. When we need something to act on the heart directly, which of these medication would we give? Atenolol. Beta 2 is mostly experimental. Non-selective is what? Propranolol. But it was the prototype of all the beta. We started with propranolol and start to have this selectivity. Although propranolol is still widely used, but you have to remember we discussed it last week, no, the beginning of the week. It should be avoided in which patient? Asthmatic patient, and it blocks what? The bronchodilation, okay? Now, adrenergic antagonists, we call them blockers or sympatholytic, usually do they trigger? And when you say a blocker, does it trigger any intrinsic effect? No. So what you're doing, you're blocking to have what? The endogenous norepinephrine, epinephrine to act on it, or exogenous medication. Also, so it triggers the usual receptor-mediated intracellular effect, also classified according to their affinity to alpha or beta, as we mentioned, or selectivity or non-selectivity. You have alpha blocker and beta blockers. So this is an antagonist. I use the same one what I used in the agonist. So when you have an alpha 1, what does it do? It blocks the alpha-mediated sympathetic response and exogenous sympathomimetic. So you're blocking the place, not allowing the norepinephrine or any exogenous to come and act on this one. Is it clear? Now, شايفين اللي underline? You have to remember them. Okay? Remember, whatever I mentioned in my slides, this is what you're supposed to know. And if you have any table, I didn't mention it in my slides, any details, you can remember them, but I'll make sure that I'll not ask you about it. Whatever it's underlined, or I put it red, or I give enough explanation in my slide, those the medication. But still, when I look at it, the slide, and to me, it's so simple, it will flow nice. But when I put the medication, I found 1, 2, 3, 4, 5, 6, 7, 8, 9, and you have too many medication to remember. Now, the easy one, the blockers with diamine, acetylol, atenolol, carvedilol, labetalol, metoprolol, pindolol, they are always ending up with what? Olol. Remember, there are some of these medication, alpha blockers, you have prazosin is very well known. You have some tamsulosin, which is more what? Selective. I mentioned with the prostate. Yohimbine is not widely used. It's more experimental, which I will illustrate more in the upcoming slides. Now, non-selective, you have phentolamine and phenoxybenzamine. These are non-selective alpha blockers. Selective, Remember, prazosin is more into alpha-1, daxozine alpha-1, tamsulosin alpha-1A, euhambine alpha-2. I'll give you more details now in the upcoming. Now, the non-selective alpha blocker actions, what is their action? First, let's talk about the cardiovascular. Alpha blockade, what it prevents? Vasoconstriction of peripheral blood vessel by endogenous catecholamine. This will lead to what? Decrease on total peripheral resistance, decreasing blood pressure, and you might have reflex tachycardia. This is the mechanism that will happen. Whereas alpha-2 blockade, what will happen? If we talk about alpha-2 blockade, you can ask me if you have any question.
We can't study that one.
Yeah, Allah. I hope there is. بس you can see my slide.
No.
لا بتشوفوا سلايد ولا طب تعالوا هنا جنبي.
I think we have to turn off the lights for that.
طب الكلوك close the lights ما في أصلا خلاص نتحرك. close the light. وليه متعذبين من الأول؟ طيب so the cardiovascular effect, which is mainly alpha-1 blockade, what does it act? Where it acts on vasoconstriction. So when you block this one, it leads to decrease in total peripheral resistance. When you decrease the total peripheral resistance, what will happen to blood pressure? Decrease. So that's why your alpha activation is what? Alpha activation, epinephrine increasing. This one it will cause a reflex tachycardia. Where alpha-2 blockade blocks what? The presynaptic. When you block it, what will happen? More norepinephrine release, enhance the reflex tachycardia. So the effect in general is increasing cardiac output and heart rate, but they're not successful in maintaining blood pressure. So, by the way, those medications, they were the first drug to control blood pressure, but now we can say they are not successful, then we have better and better medication. Now, phentolamine, let's say start with the phentolamine. Phentolamine, we said it's competitive and reversible blockers, slightly selective on alpha-2. So when it's slightly selective alpha-2, do you think we use it in controlling blood pressure or anything? No. Blocking presynaptic triggers beta receptors, they can cause what? Arrhythmia, okay? Because we have more norepinephrine. When norepinephrine is beta is open, so they might act on the beta one. Now, this is what I added. Last year I was not adding it. I was comparing phentolamine and phenoxybenzamine. Phenoxybenzamine is widely used. Yesterday I checked up to date. I want to know. This one I just put out for you so that you say why you give it to us. It was used to diagnosis of Pheochromocytoma. It was used, okay? But now, and do you know what does it mean, Pheochromocytoma? What is it? I think. Adrenal tumor. Which adrenal tumor? So what do you expect to have? High what? High of epinephrine. So if you want to do any surgery for this adrenal, what do you expect to have? Removal of it, or it's full of what? الادرينال medulla is full of what? لا والله neurotransmitter. هذا what neurotransmitters. Which is neurotransmitter? Which mediators? Which chemical? What does it include inside it? I mentioned it last week. Adrenal medulla, what does it secrete? Norepinephrine and what? So guess if somebody is doing any operation on this one, what will happen? You might have escape of what? Norepinephrine and epinephrine. Before they will give it, was used to diagnose if they have, but later on the better medication is phenoxybenzamine, which I will mention it. Or I added this before, last year I didn't give it to students. It has been replaced by measurement of catecholamine in plasma and urine. It's not of widely used, and you have to know, we have better medication. But if you open any book, sometimes let me tell you, I ask the student step will use CMLE, if they told me there are things that obsolete, but they were the prototype, they might ask you. So it's not only remember, it's your blog, and it's not the clinical when you go to hospital. Also remember you have exam, so you have to remember those medication. Now, let's go to phenoxybenzamine. It's a non-selective to both alpha. Not specific to alpha, it means does not block only alpha, antagonizes also acetylcholine, histamine, and serotonin receptors. It's an irreversible binding, so it's a more longer action. Blocks SLAX424, can be used in short-term management of Pheochromocytoma. Now I'll mention for you what does it mean, Pheochromocytoma. Tumor of adrenal medulla, it secretes what excessive amount of epinephrine. Usually what they will do, they prior to surgery patients are treated with alpha and beta as well. Also with calcium channel blockers, a lot of medication. Why they will treat them with alpha and beta? Prior to surgery. They don't want any epinephrine to go and act and causes hypertensive crisis. So you have epinephrine, it will go where? Alpha 1 or alpha 2 and what? Beta 1 or beta 2. So they block all this. They will give it prior to surgery. It's not for normal treatment or just prior to surgery. I think I don't know how many days to make sure all these are blocked and they can do the surgery. Now selective alpha 1 antagonist. So we have prazosin. انتم ملاحظين الريد, what does it mean, red color? So you have to memorize it. معناتها أكيد in my mind to bring any question. Prazosin and daxosin, it's what? An alpha 1. They cause what? Since you're blocking the vasoconstriction, they will cause what? So what will happen? Fall in blood pressure, but less tachycardia from non-selective alpha antagonist. It's used usually in these, you will hear about them, they will be used in treatment of blood pressure. Now, I mentioned the tamsulosin, which is alpha 1A. Tamsulosin, will we take it to decrease blood pressure or we will give prazosin? Prazosin. So where we use the tamsulosin, it causes relaxation of what? A smooth muscle of bladder, neck, and prostate capsule. Patient with urinary retention due to benign prostatic hypertrophy. They will cause a pressure. The one they have benign prostatic hypertrophy, they cause pressure on the urinary. So they will give them those medication to maybe in the reproductive. And I remember from before we give them urology. Now I don't know. You take urology? You'll hear about this medication, I'm sure. Okay. Some lectures it was under urology and they move it to reproductive or I don't know. Now, these are the selective alpha blocker, cause less reflex tachycardia than phenoxybenzamine and phentermine, and this one, it will be explained in the picture. So now, let's say if you have norepinephrine, it goes where? To heart and smooth muscles, right? It will act on the alpha 1 and what? Beta 1. Now, if you have a phentolamine, which is a non-selective alpha, so you non-selective alpha blockers, it is only blocking what? The alpha, leaving what? The beta exposed, so will cause what? Tachycardia. So, and then if you have selective alpha blocker, if you have the alpha 1, so this one is causing alpha 1 and alpha 2. So you have more alpha 2 to act on alpha 2, more norepinephrine to act on the beta 1. Now, if you have more selective alpha 1 blocker, it leaves that alpha 2 is what? Which is selective and opposed. You have does not increase the heart rate. So whatever I put in related to this picture, it will be clear for you. And I print this one, I add all the things that's related to this picture. Now, benign prostatic, remember I told you they have the alpha at the neck, well, that's why you have norepinephrine. I gave you tamsulosin. No, not tamsulosin. I'm sure it's tamsulosin, okay? So maybe they have this. لا check tamsulosin or tamsulosin, and I know it forever tamsulosin. Maybe it's a selective alpha 1 antagonist, relaxes what? The smooth muscle in prostate and bladder neck, decreasing degree of blockage urine flow. That's why they will give it. What is it? Check.
It's tamsu.
يعني معناتها من البوك. أو ممكن يعني بتعرف باي ذا واي مثل نور أدرينالين ونور إبينفرين مثلا بريتش وأمريكان أو مثلا I don't know هذا. What? لا, nothing is unified. Always يعني you might see يعني I know in POD you take the basic things which is يعني not rarely to be changed. This is the basic things. But later on you will find yeah, controversial, or they'll have a new medication and they will do this is better than, you know, plus how people they will respond, it differs a lot. And they will say this medication is very highly potent on those, but they were not effective on the others. Now, what is the adverse effect? Usually, because we're causing vasodilation, what will happen? Orthostatic hypotension. So you will have, you remember, lightheadedness. So what you will do, just you need, when you're lying down, to stand up slowly. Reflex tachycardia, especially in non-selective, more than selective. The non-selective, which inhibits alpha-2, when I showed you in the picture, they increase norepinephrine, leaving the what you have the beta-1 acting, increasing the heart rate. Usually we have first dose hypotension, taking it before bed, and usually first dose syncope, but by second or third, or later on they will get used to it. Usually they will tell you take it before bed so that you will not have this syncope. Usually be careful in patients with coronary artery disease and angina because of what? Anyway, it might be some patients, they have only high blood pressure, but their heart is working well. So this is why you have to be careful. If a patient that is have cardiac problem or cardiac disease or angina, so you just be careful with angina because we don't want to increase the heart rate. Now the therapeutic uses, this is like wrapping up for you. I put for you which are the non-selective Pheochromocytoma, which one we use, phentolamine or Phenoxybenzamine. Phenoxybenzamine with what? Alpha blockers and or beta blockers, Atenolol and or Propranolol. We prefer Atenolol, okay, which is beta 1. Selective antagonists, if the patient is not asthmatic, they might give him Propranolol. So don't quote me which one they will use. Honestly, most of this medication, whatever you will see, I'm sure you read in the book and you go to UpToDate and we have certain recommendation or guidelines, but at the end, you will see the clinician have their own way of treatment or because of their experience or like this. So it doesn't mean whatever we are telling you or whatever in the book or the guidelines, come on, there is the clinician expert. They are the one to decide something sometimes. Selective antagonists are useful for hypertension, but not first line. Daxoxyzine. I told you there are many medications for blood pressure safer than daxoxyzine. Urinary retention, yes, they will use tamsulosin. Leucombine, it's an alpha-2 blocker, not used therapeutically, but experimentally to analyze alpha subtypes. Usually, we don't use it. This is rain. What is it? Cleaning? What is this one? Cleaning. It's okay, leave the door open better عشان I thought it's raining to open door. Now the beta blockers main mechanism not فين. حعلي صوتي. Beta blockers main mechanism, they block the effect of what? Of epinephrine on your body's beta receptor, which is what? The heart, smooth muscles, bronchiolar, smooth muscles, and kidney. Did I say skeletal muscle? What are the blockers of skeletal muscle? أخذتوها صح ولا لا؟ ولا نسيتوا؟ والله for your own sake المفروض تكون عاملين already cholinergic agonist وantagonist والسكتل. ما أخذتوا skeletal muscle بالدكتور منال؟ Make them as a table. So what will happen? It slows the nerves impulses that travel through the heart, mainly decrease heart rate, has a variable effect on blood pressure. Yesterday I say maybe half an hour to add this, we change in this one. There is a variable effect on blood pressure. I'll explain for you لأن في alpha 1 or beta 1. I will explain it now in the upcoming slide. But don't go deep into it. Leave it when you go to cardiovascular. Because it's not the use of first line in hypertension or other drugs has more potent effect. Beta blocker also block impulsive and can cause arrhythmia or abnormal heart rate. So mainly we're talking it acts where into heart rate. Now, the general characteristic of all beta blockers, they are all competitive antagonists. We have cardio-selective, which is the beta-1 blockers. They differ in their intrinsic sympathomimetic activity. They have partial agonistic activity. Every time I give this lecture, I have a lot of questions. And I try again to simplify it and simplify it. If you are talking a beta blockers, okay, it means what? Means what? You're blocking the heart rate. When you say it has partial agonistic activity, is what? Yani there is increased heart rate. So when do you think you will give it to which patient? And I don't know if this is theoretical. What they are going to use, I don't know. Honestly, it differs from. Yani think with me, which patient should take this medication that have intrinsic agonistic activity? What? But they should have certain characteristics you want to increase the heart rate for them.
Patients under the effects of anesthesia.
لا ليش حطيت if any patient بس أنا I want to know related to the heart. If they have what? Bradycardia at resting, okay? If they have bradycardia, they prefer to take certain medication because they will have this agonistic effect. على فكرة this is دايما معضلتي كل سنة. I have to explain it clearly. And I tried this year to make it just simpler. Also, you will have it in another slide. CNS effect, local anesthetic and pharmacokinetic, no clinical use of beta-2, as I told you, no postural hypotension. Why? Because there is no alpha is functional. Alpha is functional. Okay, you worry about the postural hypertension because you're blocking what? The نعم. والله قلت والله العظيم. لأن الألفا is already active. يعني you are blocking only what? The beta. Effective in treatment. So this medication in anything related to heart, angina, cardiac arrhythmia, MI, congestive heart failure. And I put for you the hypertension, they are not the first line, okay? Hyperthyroidism, I will explain for you why they use it, hyperthyroidism, glaucoma, but they prefer cholinergic agonist, and migraine. Migraine, they will use sometimes these medication, the beta blockers. Now, the receptor selectivity, حلو الأحمر, okay? So that you remember these are the medication. Non-selective, you have propranolol, timolol, and pindolol. Beta-1 selective, atenolol, metoprolol, and acetylol. Beta-2, butoxamine. يعني ما راح أترك an important medication is related to be given in the heart to ask you about butoxamine. But I have to butoxamine. I think I have a mistake here. Butoxamine. Research only. I think it's an O. Combined alpha blocking, which is labetalol and carvedilol. I kept it for you, and they are given in pregnancy, and they are safe. No drug affecting beta-3. I don't know if you might have some. You remember beta-3 is related to what? You read if they find for us something for lipolysis, it would be great. Now, propranolol is the prototype. It blocks beta receptors. Once dose daily available. The action. Remember, a cardiovascular is what? A beta-1, right? A peripheral we have a peripheral vasoconstriction, but not related to blocking alpha-1. And I explain it. I hope someone will explain it without why you have peripheral vasoconstriction. And it may be light peripheral, but has nothing to do with the blocking alpha-1. خلاص. Can someone explain it? And I explain it in the upcoming. Yes. The vasodilation. So no more vasodilation. So expect to have little vasoconstriction. Okay. Bronchoconstriction. So I'll explain it here. So if you that's why I told you, if you understand the concept of alpha 1 or alpha 2, any question you could answer it. Increases sodium retention. If it happens somebody is taking increased sodium retention, how can we treat the patient with what? Then you have more sodium. Simple medication, diuretics we give them. Now, disturbance in glucose metabolism is very important. I'll explain it why. Fatigue and cold extremity. These are their action. Now, let's go with the heart. Before what I was putting cardiovascular action or this one, I've changed. Please don't take my lecture because I have two changes. The heart, remember, negative inotropic, so decreasing cardiac output. Chronotropic, we are talking heart rate, so it could be used in where any cardiac dysrhythmia. Blood pressure now. Blockade of beta 2, this is the way he answered it. We don't have any more what? Vasodilation. The alpha 1 is unaffected, so no postural hypotension. At the end, still we have a decrease in blood pressure, okay? Due to reduction of cardiac output, reduction of renal release from the kidney, central acting, reducing sympathetic blood pressure. So that's why sometimes we might give it to decrease blood pressure, but it's not the first line. But I don't know really, but I feel the beta blocker is always used in anyone hypertensive patient. But when we have later on, you'll hear the ACE inhibitors, you will hear what calcium channel blockers, which are more preferred over those medication. Now, the bronchioles is not beneficial. What we said, precipitate respiratory crisis in asthmatic patient, use selective what? Beta 1 blockers in case of what? If you have any heart patient, cardiac heart patient. Increased sodium retention, reduced blood pressure leads to decrease in what? When you have decreased blood pressure, renal perfusion, more sodium retention, this tends to elevate. You see how you have, when don't take each action by itself. You say, now you're talking elevating blood pressure. So I'm talking an overall, what will happen? Will you elevate the blood pressure or decrease? There is a decrease. So overcome this with a diuretics if they have this sodium retention. Now, disturbances in glucose metabolism. If anyone, usually, do you know that glucose release in response to what? To epinephrine. Usually this one is a safety device in diabetic. If you have diabetic patient or patient prone to hypoglycemic attack, how they will know that they are going into attack, hypoglycemic attack? Do you know what they will feel? Shaking, and what else? What else? Increasing heart rate. So let's say if they are, usually elder people, they have diabetes or blood pressure or heart. Some of them, they have three diseases with them. So if they will give them beta blocker and they have any attack, will they feel the shaking with tremors of hand? So you're masking what? When they feel that they have hypoglycemic attack, what they will go and take? Sugar. So if you block for them this effect, they will go into attack or they don't feel it. So sympathetic response to hypoglycemia as tachycardia will warn patient to have what? Carbohydrates. So beta blockers will block this effect, avoid in poorly controlled diabetic people. Is it clear regarding the glucose? Now, their therapeutic use is mainly what? Angina, MI, hypertension. I put it for you, not as potent as other agent. Then I'm sure you will hear about ACE inhibitors, and then ACE inhibitors are the most common use, or calcium channel blockers, but they might be given beta blockers. Glaucoma, which to decrease intraocular pressure. That's why I put for you pilocarpine is a drug of choice. Usually they might use Timolol, by the way. I put it for you. But pilocarpine is drug of choice. But yesterday I was in the ophthalmology clinic. I asked them, they use Timolol, by the way. So on what basis they use Timolol and pilocarpine? But if both they are acting, they're doing well. And to me, I know this pilocarpine is the drug of choice. Migraine may be due to central effect of blocking catechol causing vasodilation. Although the migraine, I don't know this. And when you have headache, severe headache, nothing will. Depending on how many number of medication you take, and anyone from you will have headache, severe headache, or no? What do you take? بنادول منيح اللي برسل معك البنادول. it will يعني البنادول is enough for you هذا ما انه صار severe headache. والله انا لما يجيني headache لا البنادول ولا even I take sedative to relax ولا skeletal ولا بنادول بروفين 600 يعني really sometimes really when you have severe headache okay sometimes they will give them to migraine. Hyperthyroidism to sympathetic stimulation. The other effect remember bronchoconstriction, arrhythmia on sudden stop. Never stop. Let me tell you, you'll be R1 or R2 or R3. Okay. My father, Allah yarhamu, he was on beta blockers yani for ages. Okay. He went, I don't know why he was hospitalized. He was having high blood pressure a little bit. Jail resident would stop the beta blockers suddenly. He said maybe because he has, no, I think lower blood pressure. He decided to stop the, please, when you are a resident, never take an action without going to the consultation. Well, then I went to see his file. It was from the resident. He stopped for him the beta blockers. What happened to my father? He صار عنده arrhythmia يعني really bad. والحمد لله we put him back on the beta blockers. كانت يعني حكاية في التخصص إنه how a resident will stop a medication. مشكلة لما تتخرجوا وتصيروا resident تصيروا شايفين حالكم. So don't do it honestly. يعني if you يعني affect one person, but then this one, if it goes to the consultant, I remember that resident, يعني he had a warning. They should not do it. يعني maybe you think, you know, this is the right way, but it's better always to consult or to make sure of each and medication. لأنه it's known beta blocker on a long run, they will they might cause decrease in blood pressure. Sexual impairment, disturbances in metabolism, drug interaction. Yani you have to be careful. I just start to give you drug interaction, cimetidine, fluoxetine, phenytoin, and rifampicin. Drug interaction, they might increase the dose or decrease the dose or give them on a certain different time. Yani just this is the first time I'll give you drug interaction. Also remember, you will hear in the upcoming block food drug interaction. Now I just put for you this one so that you will never forget it. If effect of chronic يعني chronic when I say سنة 1 year, 2 years, 3 years is taking beta blockers and all of a sudden you remove it from the body, this is what will happen. You have a lot of what norepinephrine acting on the receptors, expect to have what? A bad dysrhythmia. Timolol, it's a non-selective beta blocker, usually to treat increased intraocular pressure, usually is used as topically as eye drop in glaucoma. And I told you which one is preferred is the pilocarpine. Now you have this selective beta blocker, which is cardioselective. I don't want to tell you what are the medication, but they are the same medication. I put them in the first slide in red, by the way. Less effect on bronchiole, safer in asthmatic patient because eliminates factor of bronchoconstriction. We give them for hypertensive patients with impaired pulmonary. You give them what? Selective beta 1. Blocker with partial agonistic activity. Yani let me tell you, Anna, would I go and ask you a question about it? No, but wallah, you have to know it. They might, I don't know, yani, and I wouldn't have the time if up to date, it's found there. If you open your up to date, they were talking about pindolol and acetylol. They have intrinsic or weekly beta 1, beta 2. Providing low-grade beta stimulation at rest, but acting atypical beta blocker when sympathetic activity is high. They are rarely used to treat angina pectoris in patients with what? Resting bradycardia. Yani at least remember if somebody will tell you intrinsic agonistic effect, yani just to relate it if they have bradycardia. Yani Anna, what I know from my own that other medications are used for treatment of angina in addition to beta blockers. Just at least remember that certain medication they might use in angina if they have bradycardia because of their intrinsic agonistic effect. Local anesthetic disadvantage when you use topically in eye. Timolol has no local anesthetic, so you can use it eye drop. CNS effect as in propranolol. Now, the antagonist for both an alpha, labetalol, I put the red, and it's very important. Labetalol, they're effective in decreasing blood pressure, clinically predominates on beta. So you have alpha and beta, but the predominant is what? The beta. And it's used, you will hear it OB-GYN, that those medication, they will use it, safer in pregnancy for hypertension or in hypertensive emergency. What did I put here? Manipulation. This is to remind you that we don't act only on يعني medication don't act on beta 1. Also remember, you can manipulate any of these from the synthesis, from the tyrosine to the storage, also to the uptake. Now, alpha-methyl tyrosine used in Pheochromocytoma, but Phenoxybenzamine is preferred. So you have 3 now medication for Pheochromocytoma: phentolamine, Phenoxybenzamine, and alpha-methyl tyrosine. Alpha-methyl tyrosine is acting at this level from the beginning, okay? Reserpine storage, no longer used. Guanethidine, no longer used. Here where the guanethidine, I think I put them in here. Okay, I will take you this alpha-methyl tyrosine. Remember MAO inhibitors, the uptake. So you have different places to manipulate the what? Norepinephrine release. Inhibition of norepinephrine release, this is the tyrosine. This is where the metyrosine, if they use it in Pheochromocytoma, will affect the what? Tyrosine hydroxylase, which is the enzyme that converts tyrosine into what? DOPA. And then you have the guanethidine, which is affect transport of norepinephrine or prevent release. Guanethidine is not anymore used. Okay, with reserpine that affect what? Replacement, storage, and depletion. But you will hear other medication that acts on this storage and the carrier. And that's it. So if I will not go and ask guanethidine or reserpine, at least you know the concept. When you hear that they will act on the uptake or the storage, you relate it to those medication. And what are the most important medication in this class now? Everything? Is related to what? Yeah, blood pressure, yeah, what? Heart rate, or mostly angina or cardiac. You will hear more those medication, or remember that you will not hear about this medication only. في a lot of other medication, ACE inhibitor, هتترحموا على البيتا blockers. Here you heard us about the beta blockers. If you have any question, I'm gonna answer. I don't know your friend, the one. انت اللي معاك انت الباتش leader, right? Okay. Okay, I'll send you the question that he asked me when I was outside. Please, if you have any questions, I'll send it. If you send it to me, I'll send it to batch leader to have it. And don't be shy. Honestly, sometimes, like this question go see number 22, slide number 22. I was talking about alpha activation, but I put it as a footnote from down that what's inotropic and chronotropic. So he thought it's related to alpha. It's not related to alpha. It just while I'm talking about alpha, I remember and to remind you of what does it mean inotropic and what does it mean chronotropic. Good luck. When it's your final? Inshallah, I'm Taylor, so I hope. Let's hope you're studying well, or you are. Oh, best of luck. You want to take and I wish to see who's online. بس خلاص أنا مع الكورونا I drop everything. I don't want to ask. They want to put at the end they are gonna هم الخسرانين صح؟ they're not attending. خير الله ما هذول كلكم حاضرين. تعال اشوف اسال حدا موجود. والله ما يشبكم شيء. انا بخاف رب العالمين حتى موجود. مين اللي سالني هذيك المره؟ صار انه ما بعرف الاسماء ولا بنعرفكم.
لا هي مش محضر صراحه.
لا
هو هذا
لا يعني we regret when usually you have all of them, we have more interaction with the student now.